Good morning, one and all. I'm Dr. Karthick, Masters in Pediatric and Fellowship in Pediatric Emergency Medicine from Cyprus, India. And I would like to thank the Texila American University for conducting a wonderful conference. And it's a privilege to meet all you, my colleagues. Today, my topic is on hyperglycemia in pediatric head trauma patients, how we compare this hyperglycemia level and the Glasgow coma scale in traumatic brain injury. So before me going on to this topic, why I chose this? Because when I was a fellow, my first month, I had a patient, a twin child, 3 to 4 years old, maybe 1.5 years back. They have come with history of fall from height around say 1 meter with head trauma, and both the child have no open wound, no bleeding. One child was very hemodynamically stable, moving around and playing. Another child, his vitals are stable, but he prefers to sleep always. So we just monitored him for 30 minutes, 1 hour, but still he remained the same. So we planned for observation with basic investigations. When we did the RBS level, it was around 190. So we thought why there is need of hyperglycemia in this patient. Over the next 12 hours, when he was in the observation ward, he was shifted to intensive care because he was deteriorating, and the CT showed he had intracranial bleed. So this made me to go about that. So now we'll start about it. So what's summary? So this is the prevalence of acute hyperglycemia versus the Glasgow coma scale in pediatric traumatic brain injury patients in the emergency department. So a high blood glucose is common in all the neurological patients, even in non-diabetics. But there are consequences regarding the cutoff value for the blood glucose level, because the blood glucose level cannot be determined to say this patient will have a poor outcome or a better outcome with respect to the pediatric, adolescent or adult age group. Some authors believe that patients with hyperglycemia generally have a low GCS and poor neurological prognosis based on the GCS. But it's not always, but it is most probably. And it's always well known that acute hyperglycemia is as a result of catecholamine effects. So these effects has a neurological injury resulting in high blood glucose level, which I'll be explaining you later. So when the blood glucose level is related to the poor prognosis in children with head trauma, which makes the comparison studies very different, because all the head trauma patients are most commonly done in adults, whereas with respect to the pediatric, the number of studies as well as the population is comparatively low. So same thing what I said. Some authors still disagree on the association of hyperglycemia and the poor prognosis, particularly in children and adolescents, because the number of study and the quantity of the study is still less. As high blood glucose level are transient, but basically reflecting a body response. So some authors say, oh, this is a transient response, doesn't give any idea about how the patient is going to be, or it cannot be a prognostic or a monitoring of importance. In the present study, we aim to verify what's the prevalence of this acute hyperglycemia with according to the severity of head injury. There are multiple factors to decide about the assessment of traumatic brain injury, as you all know. The mode of injury, the impact, and how the patient they present to the emergency. There are multiple, but there is a blood glucose level which can be done initially with a very simple capillary test, which gives you a lot of information about this patient. Suppose we have a patient with a normal blood glucose level head trauma with a high blood glucose level with a head trauma. So what you're going to do? It will help you to guide. It plays a very important role. So the initial blood glucose level and the GCS in the emergency room will be used as a tool, but it's not the important guide, but it can be used as only a tool. We cannot say if the blood glucose levels are responsible for poor outcomes. No, we cannot. But we can only use as a guide or as a monitoring purposes. But it's not an important tool, but it's a helpful tool. So any patients with hyperglycemia, the outcomes of the children and adolescents are not yet studied, but it's been done. Okay, so there are two questions which I have put here. So everybody please look, and because this is a very important slide of my presentation. So we have a child with high blood glucose level with head trauma. His GCS is more than 13, it's good, but he has a blood glucose high. There is another category patient who has a GCS less than 8 and his blood glucose level is normal. So I will discuss these two answers later again. So how do I do this? This is a prospective cross-sectional study. Okay, this data is collected from all the medical records with respect to their age, gender, the mode of injury. The mode of injury we can classify as isolated head trauma or multiple head trauma, the Glasgow coma scale, the blood glucose level at the time of admissions, and the computer tomography scans. And age group I included is 0 to 14 years old who presented to the emergency department. Severity of head trauma was assessed by GCS score at the time of admission, and we considered the patient to have hyperglycemia if the value is more than 150 milligram per deciliter. This is as per all the authors which have done with the previous study, so I followed the same thing with evidence. And this was done in India for a period of 14 months, and so all the CT scans which had an abnormal finding like brain swelling, diffuse axonal injury, and intracranial hemorrhage are included. So, and this was being discussed with the radiologist and the neurosurgeons. So how about the exclusion criteria is patient with diabetes who has absence GCS score recorded, who has a CT scan or a blood glucose level not done in the first 24 hours, and a hospital stay patient for less than 48 hours has been excluded. In hyperglycemia, the blood glucose was determined by the capillary blood glucose through the fingertips. So we analyzed by Pearson's analysis. We found there is inverse relationship between the admission glucose level and the GCS score at the emergency department. A total of 440 patients were eligible for the study, and the mean age of the patient was 9.8, that is around 10-year patients, where 73% were male. And the most commonest mode of injury were fall from height, and next common is vehicle pedestrian accidents. So how I classify the GCS? So we classify from 13 to 15, GCS 9 to 12, and 3 to 8. So total number of patients 295 with a mild head trauma on the GCS of 13 to 15, and 70 patients with moderate head trauma between GCS 9 to 12, and 74 had a severe head trauma GCS 3 to 8. So the blood glucose at admission for 65 patients had a hyperglycemia on admission, and the prevalence of the hyperglycemia is increasing as more the severity, that is compared to mild the moderate was more, compared to moderate the severe was more. This is how it goes on. So see, among hyperglycemia patients, 83% had abdominal parenchymal changes like brain swelling, like intracranial hemorrhages. This point is important. There are 35% of the normal glycemic patient had abnormal CCT. That means 65% patient had hyperglycemia. In that, 11% with mild head trauma, 35% with moderate head trauma, which was significant, and 54% patient had hyperglycemia in severe head trauma, which is also significant. So the predominance was more common with respect to the male, and we did not observe the statistic differences between the mode of injury and hyperglycemia. So whatever is the mode of injury, we just compared as a head trauma and the hyperglycemia levels. The mild head trauma generally stay in the hospital for short period and not usually diagnosing hyperglycemia in those patients. Okay. So why this hyperglycemia occurs? This mainly occurs by the metabolic response of the high blood glucose levels. Okay. So this by effects of the cortisol, the glucagon, the epinephrine release, resulting in intracellular acidosis and neuroaxonal injuries. So that is a rise in the blood glucose level. But Abadota, in accordance with the results from other authors who also said the head trauma severity and the metabolic response to trauma are particularly high with the blood glucose levels. The abnormal CCT findings are more frequent in hyperglycemia with respect to the moderate and severe head trauma patient. But we cannot conclude if the higher blood glucose levels are responsible for poor outcomes. But this is a future study which will be done. So I would like to conclude that hyperglycemia was more prevalent in severe head trauma patients, preferably in GCS less than 8, regardless of the etiology of trauma, either it's isolated trauma, it's a polytrauma, or a pedestrian trauma, but the mode of injury. In children with abnormal findings on CT, it's very significant. So these are my references. I would like to discuss one slide. This is the slide. So what I have discussed was any patient with severe head trauma with hyperglycemia are more prone for a severe traumatic brain injury in the CT scan and their outcome, which has been studied. So this question, see, this is a blood glucose level. It's a high blood glucose with a head trauma patient which glycemia is more than 13. Sometimes it is common, but doesn't mean that this patient has no intracranial injury. This patient is supposed to be watched. Whereas the second category of question is normal blood glucose with a patient GCS of less than 8. Still, this is not a good sign, but you are supposed to keep in the watch. Over a period of 6 to 12 hours, they may have a high blood glucose level and deterioration. So, always a patient from mild to moderate head trauma with a blood glucose level, the normal stage, you're fine. But if it is high, make sure his CT scan has to be done and has to be discussed, and it has to be evaluated by a neurosurgeon. Okay. Thank you very much for one and all listening to me. Any questions, please post me. I'm welcome.
Thank you. Thank you.